Thank you, Dr. Kidangu, for inviting me here. Well, this topic has been recurrently discussed over and over again. But still, when you have a condition in which the disease is 100% fatal, and the immunization is, in bracketed terms, I would say 100% effective, you can have no mistakes being done in it. And therefore, even any number of times you repeat rabies vaccination, we are not overdoing it. And we probably, from the pediatrician's angle, I would say, Dr. Sheeja Sugunan, the associate professor in SAT Hospital, is the best speaker to talk on this. Yes, Dr. Sheeja.
Esteemed teachers and dear friends, good afternoon, everyone. First of all, I thank Dr. Pradeep Kidangu sir and the team for giving me this wonderful opportunity. So coming straight to the topic, that is rabies vaccination failures, myths and facts. So these are my major references. Unfortunately, these world bodies, they have slight differences in their recommendations because everyone has tried to add a spice or a flavor to it, which sometimes adds on to the confusion. But we need to understand that the crux is the same, the efficacy is the same. So with that, what I plan to cover would be, I will be talking about rabies pathophysiology to understand what exactly happens and why do people die due to rabies. And then we would see how to prevent this deadly disease. And finally, we would see why sometimes we are unable to prevent and what more we can do. Regarding the global scenario, we know that more than 55,000 people die due to rabies every year. And unfortunately, India is the leading country with more than 20,000 deaths happening every year. While on the other side, the WHO aim is zero rabies death by 2030. Is that really achievable? One state in India, that is Goa, has already achieved it. So let us see what we can do. So first, coming to the first one, rabies pathophysiology, we know that when the dog bites, the virus gets localized at the site of bite. It can remain at the site of bite for a long time, ranging from days to weeks to months. Then once it finds the neuromuscular junction, it enters the peripheral nerve. This is the time you're going to feel that tingling sensation. And from the peripheral nerve, it reaches the spinal cord, and that is the time you feel a girdle pain. And then the virus ascends and reaches the brain. Remember, till now, you don't have any central nervous system symptom, and till now, you are not infective. Once the virus reaches the brain and multiplies there, it travels down again from the brain through the nerve, reaches your eyes, reaches your salivary gland, reaches your lacrimal glands. This is the time you're going to be infective. We also need to know that the virus travels at a rate of 2 to 4 centimeters per day. That is the reason when you have a bite in the face, when you have a bite in the upper extremity, the chance of the incubation period is short. Whereas the lower extremity bite, the incubation period is longer. It's also important for us to remember that when you do a salivary PCR or a corneal imprint and you get a negative value, does not mean that the patient does not have rabies, because rabies virus is often excreted in a, intermittently. So at the time of death, if you have a PCR negative, then you can say it is not rabies. Otherwise, it's not right to say that it is not rabies. So having said this, that means this is a deadly disease. And this is how it goes. And it's important to understand that all you do, whether you are doing a local cleaning, your immunoglobulin, your vaccines, are going to act only before the virus enters the nerve. Once it enters the nerves and reaches your central nervous system, it is a safe haven. Neither your vaccines nor your immunoglobulin is going to act. So what do we have with us? We have a three-prong attack. That is the local wound care, the immunoglobulin, and the vaccine. The most important is local wound care. It's important that you wash the site of bite for 15 minutes with a flowing water, soap and water. This will remove 90% of your virus. And then you apply a povidone iodine or surgical spirit. It will again neutralize whatever virus that is left. If that is not enough, the next you do is you inoculate local rabies immunoglobulin. And rabies immunoglobulin, as we all know, being an antibody, it is going to neutralize the virus which is present at the site of bite. It is important that we neutralize each and every injury that has occurred. That means we have to be sitting patiently with the patient, looking for all the injuries where a dermal breach has happened and inoculating your rabies immunoglobulin. In case it's an extensive bite and you don't have enough immunoglobulin, dilute it with normal saline and instill into each and every bite. As I already said, once it enters the nerve, there's nothing more you can do. If you're washing and immunoglobulin is going to help you, then what exactly is your vaccine doing? Remember, when you administer a vaccine, the vaccine is initially taken by the dendritic cells, and then it reaches the regional lymph nodes. In the regional lymph nodes, initially the B lymphocytes are stimulated, then the T lymphocytes are stimulated, and then the B cells migrate to the germinal center, cause a germinal center reaction, start producing a large number of antibodies. After some time, these antibody producing plasma cells are going to die off and your antibody levels are going to come down. But the ones which go and hide in the bone marrow niches are going to produce continuously low level of antibodies, while some of the plasma cells transform themselves into memory cells and remain there, and it's going to help you in the future. Now, why did I tell all this? I said all this for us to remember that the moment you give a vaccine, you don't get an antibody. There is always a lag period. Also to remember that the antibody that you get following vaccine is very good and very large in number, and also to remember that after a specific period of time, the antibody levels do come down. So what exactly happens as far as rabies is considered? As far as rabies is considered, once you take an anti-rabies vaccine, your antibody titers start rising by the 7th day. It peaks by the 14th day. And so in order to cover that first 1 week, you are giving the rabies immunoglobulin. The immunoglobulin is going to be effective for 2 to 3 weeks, but it's mainly for the first week you are giving the rabies immunoglobulin. And we already said that the virus can persist at the site of inoculation for a variable period of time. So if some virus is left behind, that is going to be tackled by the vaccine. And vaccine, you can see that the antibody titer elicited by the vaccine is far higher than what you get by the rabies immunoglobulin. And moreover, this vaccine administered now is going to be of use in the future also. So now we understood how we plan to protect ourselves against rabies. So this was one of our children who was admitted at SAT with 3-year-old Devika, who had a very small 0.5 centimeter unprovoked bite in the leg. And the same day the child was taken to the local hospital and anti-rabies vaccination was started. She presented to us on day 25 with ataxia, which we attributed possibly to a vaccine-induced demyelinations, because we are always fond of finding some fault with the vaccine. But unfortunately, the child deteriorated rapidly and got to be intubated within 24 hours of admission. And that is the time we thought maybe we were missing something and the imaging was not showing evidence of demyelination. We went ahead and sent the corneal imprint as well as saliva. Both PCR were positive. So this was a confirmed case of rabies. So what exactly went wrong? So here we have to know that this child had a very small wound. That too, so-called non-risk area, it's a lower limb area she has had in the shin. But it is class 3 because the blood has come. So it's important to understand the class of the wound does not depend upon the size of the wound, it depends upon the depth of the wound. If the dermis has breached, if the blood has come, it is category 3 and rabies immunoglobulin is mandatory irrespective of the size. So here it is our fault. We have not given rabies immunoglobulin to this child. Now, and so this is what I said, even a scratch where a blood is seen warrants an immunoglobulin. So now what about the number of news articles that we came across in the last year telling about rabies vaccination failure in spite of rabies immunoglobulin, in spite of rabies vaccination? So the first thing we all said was something wrong with the vaccine, something wrong with the vaccine quality. And now we know that the results are out, the vaccines are of perfect quality, nothing wrong with that. Then we said maybe something wrong with the way we are storing the vaccine, but we need to know that rabies vaccine is a thermostable vaccine. It's not a very thermolabile vaccine like your OPV or measles. At 37 degrees centigrade, it is stable for close to 3 days. So that also looks unlikely. So when we could not find fault with the manufacturer and the government, we turned to the administrator. Is there something wrong with the way we are prescribing or we are administering? We need to know what is an invalid dose in rabies. A rabies vaccine which is given intramuscularly in the gluteal region is invalid because gluteal region has lot of fat there, and when the vaccine is administered in the gluteal region, if inadvertently it becomes subcutaneous, it is invalid because number of dendritic cells in the gluteal region is less. Similarly, when you give a vaccine in the intradermal plane, if it does not produce a wheal, it is invalid because the number of dendritic cells in the dermis is far higher, but subcutaneous plane, as I already said, has very less dendritic cells. So if that happens, then and there we need to repeat the intradermal dose. So now the question comes, is this intradermal dose really good? That was one question that was asked. We need to know that the WHO recommended the intradermal dose way back in 1992, and India adapted it in 2008. Until now, neither the government of India nor WHO has withdrawn. In fact, it has led worldwide to a decrease in incidence of rabies death because of increased uptake of the vaccine. So this is not a failure story, this is a success story. But still, who is better? The intradermal or the intramuscular plane? In fact, if you look at the antibody titers, the intradermal plane gives you a higher antibody titer than the intramuscular plane. And WHO also categorically says that the vaccine efficacy is equivalent to or higher than that of the intramuscular plane. So now we understood that it is not the route of administration that is causing the problem. But if you really look at the 6 cases, deaths that happened in Kerala, in 2022, you would realize that there is something similar. All the cases where the death happened, they were immunocompetent, and the bites were mainly in the face and the hand. So what is the importance here? The reason is because these are highly innervated areas. Being highly innervated areas, the chance of virus finding the nerve is definitely high. The next, if you see, you can see that the first symptom is appearing by the 2nd or the 3rd week early, which basically means that at a time when your vaccine is supposed to be effective, start producing antibodies, you have already started developing the symptom. That means the virus has entered the body long back. So that importance of washing the wound, importance of administering the rabies immunoglobulin, importance of the first 3 doses of vaccine are also important. And here you can see all the deaths are happening within 1 month of the bite. So the day 28 vaccine is not of much use. That's the exact reason why the WHO no more recommends the day 28 vaccine. The CDC has done away with the day 28 vaccine way back in 2010. So we need to understand that the initial part is very important, and we also need to understand. But all said and done, still why does it happen? So when you look at the CDC data, it's also the same. The highest incidence is happening between day 14 and day 30. So one of the reasons we need to understand is that in India, the frequency of animal bite is 1 every 2 seconds, and death is 1 in 30 minutes. And what is in Kerala data? Our Kerala data is in 2022, we have given 2 lakh vaccine bite for dog bites and another 2.5 for cat exposures. So when your denominator is going to increase, the rare phenomenon of vaccine failure is also going to increase. And that happens usually when the bite is right on top of a nerve. The chance of the virus entering the nerve is more, and there is a risk of vaccine failure. Now that comes the question, does that mean we accept these vaccine failures and we say we have nothing more to offer? No, we have something more to do. And something more is definitely vaccinating the pet dogs as well as the stray dogs, and also pre-exposure prophylaxis. Pre-exposure prophylaxis, especially for the high risk, it is now recommended by the Indian Academy of Pediatrics for all children less than 5 years of age because they're unable or they might not really tell you an exposure, or all the sites of bite may not be identified. So in children, definitely a pre-exposure prophylaxis is now being increasingly recommended. The dose is 3 doses, 0, 7, and the third between 21 or 28. You can take it intradermally, you can take it intramuscularly, whichever you want. But we need to know that the goal of pre-exposure is different for different people. When you or me are taking a pre-exposure prophylaxis, we are basically looking at to prevent ourselves from a vaccine failure, that is protecting ourselves against a future known exposure. When a veterinary doctor takes a pre-exposure prophylaxis, for him, he is preparing himself for an unknown exposure because he is constantly at threat. So veterinary doctor requires frequent boosting so that he has an antibody level above 0.5 MIU so that he is protected always. You and me don't need to take a protective booster, then why are we taking? We need to understand when you take 3 doses of the vaccine, definitely you have an antibody level which is above the protective antibody level. But by 3 to 6 months, this antibody level is going to go down below the protective level, making you again susceptible to the infection. But if you have already taken 3 doses, the moment you take a booster, the old story of being taken away by the dendritic cells, going to the B lymphocyte, all that is not needed. You immediately mount a good antibody response. Why does it happen so? If you've already taken the 3 doses of rabies vaccine, there will be enough memory cells in your body which normally are doing nothing, moving around. But the moment a booster is given, the memory cell identifies the vaccine and immediately converts itself into a plasma cell and start producing a lot of antibodies. So the idea of pre-exposure prophylaxis is creating a blank balance of good memory cells against the rabies virus. So what are the advantages? The advantages is first 3 months, no further vaccine is needed in case you have a re-exposure. For a lifelong, any re-exposure, you just need to take 0.3. There is no need to take a rabies immunoglobulin for anyone who has taken a pre-exposure prophylaxis. Since enough memory cells are there, you don't require it. And no vaccination failure has been reported in those with previous pre-exposure prophylaxis. A word about the most vulnerable one, that the immunocompromised. Remember, for them, both category 2 and category 3, you require a rabies immunoglobulin. And every time an immunocompromised person encounters a bite, you have to treat it as a new case and offer him vaccine and immunoglobulin as indicated. And also, if the patient, especially on biologicals, it is important you check the rabies antibody titers 7 to 14 days after the first dose of vaccine to decide whether extra doses of vaccines are needed or not. So that finally concludes with the take-home message. That is, number 1, educate the patient as well as healthcare personnel regarding ways to prevent rabies. Number 2, definitely vaccinate and prevent rabies. Post-exposure prophylaxis is highly effective. And in order to eliminate rabies, the only solution is we have to vaccinate pets and dogs as well as offer pre-exposure prophylaxis. So the final message, if our mind can conceive it and heart can believe it, we can achieve it. So rabies 0 by 2030 is achievable. Thank you.
Thank you, Dr. Sheeja, but I would thank you very much for your presentation. But the golden question which keeps asking is this vaccine 100% effective? And Dr. Sheeja has said it, but I would remember the words of Dr. Joy Philip, who used to say nothing is 100% in medicine. And in fact, in 2007 itself, the WHO has publicized from Thailand, where the original regimes were said that it was failing in certain things. Why I'm emphasizing this is, once you say everybody is effective, the poor person who gave the vaccine gets into trouble. Therefore, if there is a DHS or a DMO here, or the IMA gets involved in it, please remember there are references published by the WHO in New Scientist which says that the vaccine is not 100% effective, whatever be the storage. And as Madam very clearly stated, when you have too many cooks, they spoil the broth. We have a national guidelines which says many things against what many things the IAP says, though the pediatricians are there in the national guidelines. The classical thing will be the pet. What do you do when you have a bite by a pet? The CDC says, the WHO says, you can wait. If it is fully immunized, the pet is more than 1 year old, and the second dose is received after 1 year, the first dose after 3 months, don't immunize the child. Don't immunize, you can observe. But the national guideline says, no, we cannot believe the vaccines which are given. It's the national guidelines, you understand. Don't believe the vaccine which the Indian government is giving to the pet. You better immunize him from the beginning. Therefore, there are stark differences in this. And finally, what did the Indian Academy of Pediatrics in the previous immunization book say? They went with the CDC recommendation. The purple book which came here, I was looking for it to open it and see. They did what was most diplomatic. They just kept quiet on that. Therefore, if you have a pet at home, if it is bitten by a pet dog, the pet is completely immunized. I would say if you keep a pet at home, not only immunize the pet, as Dr. Sheeja said, give pre-exposure prophylaxis to your child at home. Please do that, because he will put your hand inside his mouth. It will lick his tooth. Once the saliva is there in this mucosa, he kisses. It becomes grade 3. There's no point. You will have to give anti-immunoglobulin. Therefore, these are important points which I would like to say. And very well, thank you very much. This is always a topic because you have a 100% mortality disease and are supposed to have a vaccine which is 100% protective. That puts the health worker in lot of difficulties. Okay, lot of responsibilities, I would say. And not everybody listens to talks like Dr. Sheeja. Thank you very much.
Sir, it's not rabies, dog carrier stage is not there. Other animals, carrier stage is definitely there. Rabies, if a dog, like old concept, why do we say that if the dog has bitten and dog is normal for 10 days, you don't have to be bothered? We used to say that, right? That still applies. The reason is because once the dog has the rabies virus in it, and once it reaches the brain and reaches the saliva of the dog is unlikely to survive beyond 4 days. The incubation period, once it is infective, is only 4 days, maximum 2 weeks. So a chronic carrier stage where the rabies virus can be excreted through the saliva of the dog has not been described. In other wild animals, it's definitely there. Even, no, it's irrespective of whether it is immunized or non-immunized.
Excellent, Sheeja. Will you consider universal immunization for all this? Because, yes, myself, yes, here.
Recently, there was a tour, ENT tour last week. So I was in half mind whether I should go or not. But still at night, I packed my bag. And at 11:30, I gave my pet cat some antispasmodic, he had abdominal pain or something. And he just scratched me on my nose. So I cancelled my tour the next day. I went to medical college. They said that it's not 3 months since I was vaccinated. So I didn't take that. But every time I get a scratch, I go to medical college. But whenever this topic is talked, always I say that before we send our next space mission, do something to rehabilitate all these dogs. I cannot have a morning walk coolly in NCC Road, full of dogs.
Yes.
And recently, our medical superintendent said that she didn't have a good night's sleep. I said, what? She said she saw that video where a kid was bitten. But we've all seen that video. And why is the government not doing anything to rehabilitate these dogs? We're going for space missions. We're going for everything. But why can't we rehabilitate this dog? Forgive me, animal lovers. But I'm not telling to punish the dog, but at least rehabilitate them. Yes.
So, will you consider universal immunization for rabies?
I think that's a big decision because it will be involving a lot of money. So that is why...
Consider this is cost, that might be more cost effective. If you look at the cost of RIG and look at the cost of complications.
I think at the first measure, it should be the high-risk persons who should get immunized. And the second measure, definitely, if we are not able to control the dog population in India, you would require immunoprophylaxis.
One thing which I would like to say is we would always like to say the health service gets the better immunization. And we are still giving the rabies immunoglobulin. And in the Western world, they are giving here we are giving the equine, the Western world we are giving the human. And the private, they are giving the monoclonal antibody, which was first produced by Serum Institute. Serum Institute is the first place in the world, I think, to produce monoclonal antibody. Now, Cadila has come out with a product. And for the first time, the Indian Academy, last time the book, they said, you can give either of them. Now they say, categorically, monoclonal antibody is better than that. Am I right, Dr. Sheeja? In the purple book, they have given that. And therefore, if you go to a government hospital, better go to a private hospital. Thank you. I may not openly say that, but that is what it is. If you want monoclonal antibody, the IAP says categorically is superior to the equine rabies immunoglobulin.
No, there is a slight difference of opinion, sir, because monoclonal antibodies are highly effective, but this one is just against one single isotope. So if it goes in for a mutation, the monoclonal antibody single isotope won't be really effective. So what is really recommended is the 2 combinations of monoclonal antibodies that would be more desirable. And for us, we also need to know that the Indian government has not yet given approval for the monoclonal antibodies. So that is there. And rabies virus mutation in dogs in India has not been reported. And mutations are usually there for bat rabies. Bat rabies is also not reported from India. But bat rabies has been isolated from bats in Andhra Pradesh. So it's a controversial topic. As of now, taking of monoclonal antibodies is equally efficacious as the other one. But I would not put it as a superior because it is a single antibody.
Thank you, Sheeja Madam and Padmanabhan sir.